Hello, everyone, and thank you so much for joining today's Max Insight webinar, Overcoming Barriers to Breast Cancer Treatment in Sierra Leone. I'm Kathy Skippers. I'm the Region 8 for Africa with the Max Foundation, and I will be your host and moderator for today's discussion. I'm very grateful for you giving us this hour and spending time with us, and I really hope that you will also share your questions and also be part of the discussion as we lead towards the end of the session. But before we dive in, I'd like to quickly go over a few housekeeping items. I so wish it could be in person, but since it's a Zoom webinar, attendees' cameras and microphones are disabled for the duration of this call. You will only be able to see today's panelists. At the end of the program, we will hold a Q&A. So throughout the hour, as you have questions or you have a thought, please proceed to post those in the chat. But before we go into that with any questions, I'd like to perhaps encourage you to also share where you are viewing from today. If you'd like to utilize subtitles during this webinar, please click on the Zoom settings at the bottom of your meeting screen to enable personal closed captions. And lastly, this webinar is being recorded and the recordings will be shared to your email list in the coming days. So let's kick it off. And today you'll be hearing from a panel of experts to discuss the barriers for advanced breast cancer in Sierra Leone. And as we discuss these barriers in Sierra Leone, I also want you to envision this not only specifically to this country, but it also applies to so many of the other countries we find ourselves working in. During this discussion, we will also highlight how we can work together to improve access to diagnostics, treatment, and holistic support for those patients that need it the most. We'll explore topics like the impact of cultural stigma, the importance of continuity of care in the areas, in remote areas, and the specific tools and resources needed to ensure successful treatment and improved outcomes. Before we go into the discussion, I know many of you have been friends of the Max Foundation for many years, but there might be a few newcomers, and I'd like to take a moment just to share more about the Max Foundation and who we are and why we are here. The Max Foundation core mission is to accelerate health equity, and we believe that access to treatment and medicine is a human right. We fulfill our mission by delivering medication, technology, and services to patients facing cancer and other critical illnesses, focusing our energy on those no one else is helping. We know that globally, 6 deaths are related to cancer, and approximately 70% of deaths occur in low and middle income countries. By bringing treatment to patients facing these inequities in access, we can save tens of thousands of lives, and not only change lives, but change communities and health systems. We want to bring medicines, and we believe that geography should not be destiny. And we strive for a world where all patients can live with dignity and hope. For those of you new to us, the Max Foundation was first established in 1997 in honor of Max Riverola, the stepson of our CEO and co-founder's son. Max was diagnosed with chronic myeloid leukemia at the age of 14, and because the treatment he needed was not available in his family's home country of Argentina, they had to go to the United States to seek access to this treatment. While Max tragically passed away a few years later, his legacy lives on through our work and our mission. The organization aims to ensure that other families do not have to suffer in the same way, knowing that there is treatment available, but because of where they live, it is not accessible. And through our extensive network and years of partnership with global partners, the Max Foundation now provides 15 types of medicines for 14 cancers and rare diseases, spanning across more than 80 countries. And we are reaching more than 37 patients annually. We work with nearly 500 physician partners across 300 institutions living and working in the countries and the patient where we serve these patients within their own communities. And while MAX began as a blood cancer-focused organization, we've rapidly expanded our profile and portfolio to serve more patient populations in need. As many of us here today know, breast cancer remains the leading cause of cancer-related mortality amongst women, and even more so in the developing countries. To address the unacceptable inequalities, the Max Foundation, in collaboration with the Advanced Breast Cancer Global Alliance, oncologists, pharmaceuticals, and diagnostic companies, and professional organizations, launched novel advanced breast cancer access program in 2022. This initiative seeks to expand access to life-saving medications and to sustainably strengthen health systems in resource-limited settings. As of this past August, I am pleased to share that nearly 600 women across 12 countries have begun treatment through the Max Foundation's program. This is a drop in the bucket, and I know for sure that we can do more. We are currently expanding to expand our work to reach more countries. And one of those countries and partners we'll be talking to today is specifically in Sierra Leone. With that said, I'd like to kick off the discussion and start introducing you to the great panel and those of our supporters online here today. So today we have 5 wonderful panelists, all who are amazing partners of the Max Foundation and have ties or have now new ties to Sierra Leone. I'd first like to introduce and welcome Cremelda Parkinson-Pratt. She's the CEO and founder of Thinking Pink Breast Cancer Foundation. We met a few years ago at an international conference, and hearing Cremelda's story and the need for patients' support in Sierra Leone, I knew we had to do something and help them change the outcomes. Thinking Pink is a nonprofit organization based in Freetown in Sierra Leone. They focus on disease education and screening for breast cancer, believing that early detection is the key to saving lives. They also do a lot of engagement during World Cancer Day and World Breast Cancer Month, and specifically also host annual conferences geared towards improving outcomes for women and girls. Welcome, Cremelda. Cremelda, as we welcome you to this, I'd also like to jump into the first question. And we understand that there are so many barriers that prevent women from seeking help in your country. But what would you highlight as the biggest barriers you face currently in Sierra Leone for the improvement of patient outcomes?
Thank you, Kathy. The barriers are enormous, as you may imagine. But this includes limited access to healthcare and affordability. Poverty is also a strong barrier, out-of-pocket costs and expenses for treatment and medication. Low awareness, misinformation, and the literacy levels. We do have a fragile health system, and the scarcity of professional, skilled health workers, especially in the rural communities. Inadequate survivorship care, including support for emotional and financial support. We also have policy gaps and funding gaps. These are all the barriers that are indeed wrenching our country and causing so many deaths through cancer. A lot believe that cancer is a punishment. There are so many stigmas, religious, cultural, that breast cancer happens to be a curse, that it is a witchcraft attack, that you are condemned in society. I want to share a very short story about Miss A. She was a 20-year-old girl who first contacted breast cancer when she was 16. She had a fungating breast cancer tumor. She was in the remote villages. Somebody called us about her situation. She was thrown outside her own house with a family because of the forgetting situation. We went there. It was a serious mass, but there was no transportation because the transportation network from the interior is terrible. We had to contact Freetown if we can hire an ambulance to come and pick her. We finally got one. She finally came to Freetown, which is the only place in the country for treatment for cancer. Eventually, Miss A died. And so transportation is such a barrier. So transportation to and fro doctors' visits is crucially and serious. Some women last week were at the chemo center, and a lot of women were telling us they normally don't come. They miss cycles because they cannot afford their own transportation. So these barriers, they are so important because the geographic remoteness of some of these to access treatment, especially with very little or no knowledge about breast cancer, makes it so crucial. And so I can go on all day, but these barriers do contribute to late treatment and poor outcomes.
Thank you so much, Grimelda. I think it's so insightful. So often we hear it's lack of treatment availability, but we also know that availability doesn't mean access. And I think this was a really great example of what that means in real life is having something at the end of the tunnel, but yet you cannot cross it. And I think there are a lot of those stories that we hear frequently, but I want to hand over to Dr. Peter Veldsteke. He represented ABC when we recently traveled to Sierra Leone. Peter, you joined us as an expert. I know you've also worked you in your profession as an oncologist, and specifically you are from Brussels, Belgium, but you've worked in Botswana for a few years, and I think that's where our paths crossed the first time. But going with us to Sierra Leone, I'm curious to see what did you experience from that trip, and what from these barriers that Ms. Grimelda just shared, what did you also experience firsthand, and some of the solutions that you think we can apply to those barriers that we just brought up?
Thank you. Thank you. I absolutely agree with what Ms. Grimelda just said. The barriers are there, but I also saw solutions that are already in place or that can be put in place. So one thing, for example, indeed, is the issues in referral pathways. For example, it's hard to get a patient from the districts or from the remote places to the central hospital, which is Connaught Hospital. Patients end up first in the general clinic, and then before they get to see the oncologist or the surgeon, it takes a while. But there are solutions there, and for example, Thinking Pink is already offering those for breast cancers patients. We're navigating them, and that brings us to the idea of having actually installing a navigation program, which is actually being installed in quite a few countries now, and that is really a game changer at a very low cost. But as long as that is not there, simply sharing information through a WhatsApp group or sharing telephone numbers can save lives. I'm thinking, for example, lately when we were there, we found out that actually patients could get the staging of their cancer done with CT scan at the Mercy ships that are there in Freetown for free. So those things were shared and are valuable in sharing. So another issue that I saw was the difficulties indeed in organizing an MDT meeting, multidisciplinary meeting, where all the specialists are together and discuss the treatment of the patient before the treatment actually is being installed. And for organizational issues, it often is hard to make it happen. But obviously, one solution could be is to make it partly virtual and in person, so that those that cannot join can at least join virtually, and that is possible now. For the barriers to diagnosis, we saw that, and we will talk about that, is the pathology issues in getting immunohistochemistry, particularly in breast cancer, to get the hormone receptors done. There's a lack of access to that, just merely because of the buying of the reagents mainly. And so therefore, a lot of patients receive chemotherapy. So in that sense, there's kind of a chemotherapy overuse and a hormone therapy underuse. And we all know hormone therapy is much more targeted and probably better than chemotherapy if it's not needed. So, but solutions again there is that Max Foundation has brought in this Strat4 machine, which is a PCR machine, which does the job of the immunohistochemistry in only 2 hours, and that machine is actually being validated as we speak. So this brings hope, and another, as long as we cannot access that, or if for other reasons one patient could not access it because it's in Freetown, well, the potential of trying hormone therapy as a neoadjuvant approach, like just giving it and see what it does on the tumor, and if it shrinks, that confirms your diagnosis is actually hormone receptor positive disease. So bringing in that Strat4 machine not only will help for the program of CDK4/6 inhibitors, but it will also help all of those patients that are not at that stage yet, that don't need the treatment yet, but can be treated correctly with either hormone therapy or chemotherapy. For treatment barriers, as Ms. Grimelda said, there's the cost of the chemotherapy, there's a lack of rated therapy, there's the transport costs. But I see the solutions there also. The chemo is actually being bought by the patients in the peripheral pharmacies, and we don't really know what quality is of that chemotherapy. And one solution could be to centralize the buying of the chemotherapy by the central pharmacy, so prices will go down, and it can be done through foundations like IDA that can provide those therapies in a very secure way. For radiotherapy, work is ongoing, and the government is really helping with that and pushing that, so that the IAEA, the Atomic Agency, helps in putting in place radiotherapy in the country, and that is very often at a very reduced cost if we do it through the IAEA. So that's very good news. And as transport issues are already being helped by the Thinking Pink Foundation by offering transport for those patients that need it. And then the last thing that Dr. Prof will address that is that we saw so many young patients with breast cancer, and that brings us to the fact that in Western Africa we see a lot of young patients, and most of them, in Ghana at least, we know that are triple negative. So a lot of them are probably BRCA positive. So if somebody is listening there and has a BRCA access, can facilitate that, please do, because that's going to save so many lives just by prevention once you know the BRCA is positive, the gene. And as long as that machine is not there, one could say, okay, this lady is young and has triple negative disease, maybe we should start screening her family so that we detect the cancer in time in family members. So those are some thoughts about barriers and potential solutions, and of this fabulous trip that we did in Sierra Leone.
Thanks, Dr. Peter, and I really appreciated you also joining our trip. And as much as we come across these barriers, it's always enlightening to hear that there are potential solutions, but I think those solutions are brought by a community where we work together, and I think we're at the right start. If we're working with Prof. Babatunde and Ms. Grimelda, and taking this forward as a mission in a country like Sierra Leone. But Prof, I'm going to hand it over to you, and I know you've also been extensively working in this area. You stood up as a champion and said you want to change the outcomes for women with breast cancer in Sierra Leone. I recall in one of our first calls, you specifically said we cannot do what we cannot treat, or what we cannot diagnose. We cannot treat what we cannot diagnose, and therefore you're a big champion for the diagnostics. But we've come across something very interesting in Sierra Leone, and that is the young age. As Dr. Peter also said, we know women in Africa present younger, but this seems to be a very young cohort. Maybe you can tell us about the average ages of where patients present and your thoughts around that, and what we need as a community to specifically serve these younger women in this disease area.
Yeah, thank you, Kathy, for the question. I've been here now for close to 5 years, and the first thing that I noticed was that before then, breast cancer was treated empirically. Clinical information, excuse me, examination, those that can afford it, they send their tissue abroad, and it takes months before they get results. Sometimes the patient is already dead before the result comes. We got here, two of us, we started the practice again, which was present years back, and there was a time of no pathology service. But one thing that is amazing, though not peculiar to Sierra Leone, is the fact that most of our patients are much younger than what it takes in other climes. I would say that the median age here is around in the 30s. So we have breast cancer patients from 20s to 30s, 40s, that density. By the time 50, 60, there are not as many as those that are less than 50 years. Which is something that's worrisome, because at that age, that's when people are most productive. And the only thing we can offer is just to do histology. So these young people that may be hormone sensitive and that may have good prognosis, we couldn't separate one from the other. So everybody is giving chemotherapy, sometimes supported by tamoxifen and all that. So it's a very tough thing. When I first came, anytime I'm traveling, I will carry tissue, go and do immunohistochemistry for them. But I know that was not sustainable. I got tired after some time. And so I remember when I first joined the Max Foundation meeting before your visit, my statement was what you quoted: how do we treat what we cannot diagnose? Breast cancer is not just histological diagnosis. That's just a preliminary testing. And so we needed to do something more. And I think that was what led to the gene expert that was donated, which we have also started working on. The immuno has been done for the validation. We are just waiting for training so that we can validate the equipment and we can roll out testing for HER2 and ER, which in no small way will help these younger people to live a fairly good life, even with the cancer. Because I know that if we continue with this empirical treatment, chemotherapy for all, those that will respond, those that won't respond, will not respond. I don't think that will benefit the country. And I'm also trusting that, like Cremeda mentioned, that we will extend the practice, the pathology practice, beyond Freetown, because people having to travel from the interland to Freetown is a very big deal here and all that. I think that will help us in no small way. We are trying, I know we did a publication earlier in the year looking at the ages and all that, and some survive. No, we didn't do survivor in that, but we had a publication with the surgery department on breast cancer outcomes and all that. The outcome is still dismal, and is because we are not able to subclassify these cancers for proper treatment. So, but with your support from Mass Salvation and ABC, I think that we're on the right path in the country. Thank you.
Thank you, Prof. I appreciate that response and the feedback, and it's good to hear that the support is helping you towards a corrected path, if we can use that language. But I want to hand over to Edgar. Edgar Thomas, you initially you started as a board member for the Max Foundation, and now you're also no longer the board member, but the chief financial officer. But what makes this such a great occasion is that you hail from Sierra Leone. You are a Leonean, as we would say, and grew up and raised. So with that in your heart and the culture of the country, what would you say would be the experience in how can we leverage a community to change the situation for women and girls in Sierra Leone that face this dreaded disease?
Yes, thank you, Kathy. And yeah, no, it's really a privilege to be here and join the Max Foundation full time. And for me, personally, it reminds me a little bit of when Ebola broke out and I joined the Partners in Health and moved to Sierra Leone. And I'm an accountant by training and kind of like using my skills to kind of contribute to the effort. The same thing here with the Max Foundation. So as folks in the diaspora and in the country think about their skills, thinking about how those can translate to that effort is very important. Obviously, financial support would be very helpful. As you know, here at the Max Foundation, we're focused on access, not just availability. So we, as Carmelda was talking about, Ms. Carmelda was talking about transportation and all the things to get patients to the facilities. And really raising awareness, as people out in the diaspora. I think it'd be very important for us to kind of raise awareness because when I was there in February and met with Ms. Carmelda and talked about the ages of the patients, it really broke my heart as a human being, quite frankly, not just a Sierra Leonean, to see people being struck down so early in life. And this is the most valuable asset that any country has. Sierra Leone has a very young population, able-bodied, and if we are seeing our citizens dying at that young age, as Prof said, kind of when most active, most productive to the community, it is a tragedy. I think what we're witnessing is a tragedy. And I think I'm very thankful that the Max Foundation and organizations like Thinking Pink are really working to make a difference. So I think for all of us, whether we are in the diaspora or just as human beings, I think coming to webinars like this, contributing financially when we can, raising awareness of the crisis, are all things that we can do as as non-clinicians, kind of looking on the sidelines. So I encourage everybody, kind of as they take this webinar and take the information that they hear today, kind of internalize it, but also spread it out to other folks, because I think that's the way we make a difference.
Sure. Thank you, Edgar. And I want to, as we talk about bringing skills together and bringing the global community and how we can contribute, I want to introduce Dr. Fatima Cardosa. She's the president of the Advanced Breast Cancer Global Alliance, and she joined the Max Foundation and HPACT, and her organization represents in saying, how can we partner together to change the outcomes for women with advanced breast cancer? And Dr. Cardosa, I've had the privilege of having you accompany me on several trips across Africa. We visited several clinics, met with patients and physicians alike. And my question would be are there some of the similarities that we see here in Sierra Leone across the region? And in terms of the community, and as Edgar also said, skills and support, what do you think we can do as a global community to uplift these countries specifically like Sierra Leone?
Thank you, Kathy, and hello, everyone. It's a pleasure to be here. I was listening to my fellow members of this webinar, and I was thinking we did not say what we were going to say to each other, but we are going all into the same direction. And I think that although every country is unique, there are common hurdles to many of these countries. And I think that when we look at the huge problem, let's say that even we as individuals, when we look at too many difficulties and needs simultaneously, what we would like to do to tackle the problem is to know how to prioritize. we cannot tackle everything at once. It's not possible, and we would be lost. So how can we make a plan and prioritize what needs to be dealt with first? And I think that's where the global community has the responsibility, not just to share resources, but also to share knowledge and experience. And when I say experience, is experience of what works, but also of what does not work. Because you can save a lot of time in a country if you don't go down a road that someone else already tested and it's not a good idea. And so you can save time and money and resources by learning from other people's mistakes. And I think prioritization is crucial, but it's also very complex. And when you listen to discussions or you go to meetings, a lot of people are focused on the new latest technology or the new latest expensive treatment. But in fact, the basis for a good cancer care is not there in the latest and more expensive treatments, but it's on having an accurate and timely diagnosis, understand the characteristics of the disease in breast cancer and in other cancers, fundamental to know why do we need the immunohistochemistry that we talked about. Why do we need that? Because treatment is different according to those characteristics of the disease. And so having a proper diagnosis and a proper characterization of the disease, and then a timely initiation of treatment. What is common in many countries is the time between a symptom and the start of the treatment is a huge time. And we lose very often the opportunity to cure the patient because of this time that goes by. And so I think that if everybody understands that with good surgery, good radiotherapy, and the number of what we call essential medicines that are not expensive, that we can treat more than 80% of cancer patients. And so why are those things not yet available for so many cancer patients around the world? Even non-expensive treatments are not available, and there are shortages. So I think that's the responsibility of the global communities to help the physicians in the field, train them, but also give them the conditions for them to remain in their countries and practice in their countries. And the last point I wanted to make, that we always fight a lot, that we treat the patients according to guidelines. But when we go and read the guidelines, they almost all of them assume that you have access to everything. So they are not helpful. And what the guidelines should be is resource stratified and say, okay, if you cannot get the best treatment, what is the second best? Among your resources, what is the best that you can offer to your patients? So that's our responsibility as a global community.
Thank you, Dr. Cardosa. I really value that sentiment. And I want to pass the ball now back to Ms. Grimelda on something that you've just said. And I need to also just share with the audience that at the moment, the Max Foundation and our partners like ABC, we're working to provide patients in Sierra Leone with access to a CDK4/6 inhibitor as a humanitarian aid, or that as a donation, so that they can actually have prolonged life, good quality of life. But Grimelda, we've just heard that the time from symptom to the time of treatment is critical, and that we can save 80% of our patients if they present early. Maybe we can go back to the topic of stigma. We understand there are these like systemic barriers like transport, navigation, sometimes lack of knowledge in the regions. But can we speak towards those beliefs or inherent discourses within the community that actually prevents women from seeking help when they first see the first symptoms of something like breast cancer?
Yes. For me, I think a lot of women deal with shame, blame, embarrassment. Who do you go to? The awareness is low. The family most of them don't understand what's going on. So, if your family, the closest people to you, cannot like guide you through what's going on, it leaves you in a confused state of mind. And so most of these patients suffer and suffer, sometimes until death, some until advanced stage. And that means somebody who knows a little bit about what's going on maybe will guide you to maybe the hospital or maybe to Thinking Pink, for diagnosis. So it is such a complex, breast cancer is a very complex issue in this part of the world. Women are very shy about what this is. You hardly meet women who will just talk to you very openly about their diagnosis, So we need a lot. We need things like the spiritual side also is something we shouldn't forget, because most of these women are, they're all religious in one way or the other. So they have guidance from their religious heads, that maybe can lead them to places like Thinking Pink. It's not so easy. For me, that's why I always say we have to elevate the awareness level. Let women know what signs and symptoms they should look for, and at the onset, what to do about what's going on with their breast.
Thank you, Crimelda. Peter, I'm jumping to you, and I know this might not have been one of the questions we posed earlier, but I want to go back to your experience in Botswana, and I think there was also a lot of work done in the area of awareness and stigma. Did you also see some of these cultural barriers there in terms of beliefs? And as a clinician in that setting, how do you manage the conflict of the cultural belief versus the treatment that you want to provide?
Okay, yeah, no, I absolutely agree with the fact that religion or cultural beliefs interfere sometimes with treatment. But first of all, what we try to do is figure it out. If there was like a silence when announcing the diagnosis and the treatment plan, then we kind of said maybe we have to go further here. We were so lucky to have from time to time also the help of a psychologist helping out just after our first talk. And if we found out that in fact there was cultural beliefs or religious beliefs, then we would try to reach out to the person that they would try to contact and talk over it, and proactively go to them and say, this is our plan. We do not want to interfere with your plan, but we want to be complementary. So, because sometimes patients see it as that is what I'm going to talk about with my pastor, and it's going to be opposed to what the plan is being given in the hospital plan. But it doesn't necessarily have to be like that, and that's mainly the most important message that we wanted to give, that we were not we would not be opposed to what and most of what for example, if it's a pastor, is probably with good faith, and most of that would be compatible with the treatment that we would give. So these things can help out with getting the patients to accept her treatment on top of her or next to her beliefs.
Thanks, Peter. And then I want to put a question, discussing all these barriers. We understand there are solutions. We've heard of practices now being applied in other countries, and even the perspective from Dr. Cardosa in saying how we need to prioritize what we do as a global community to support. But I want to highlight our guests here on the panel from Sierra Leone in a moment, and I will go around. And my question to you would be is, what would you like to share about your dream for the future for breast cancer treatment in your country? And what do we need to help you to accomplish this dream? And maybe I'll start with Edgar Kremelda, and Prof, you've got a second to think about this question of what is your dream and how can we help? And I want to say, I know we only have 20 minutes. This might be an hour discussion for each of you, but if you can summarize that. But Edgar, let me put you on the spot first.
Yes, no, thank you. And I think, like I mentioned earlier, and we all the panelists have mentioned how great the need is. And I also mentioned my experience with Partners in Health during the Ebola crisis. And it's very exciting for me personally that the Maternal Center of Excellence is being opened in Kono District next month, which was something back when we were doing Ebola was kind of a pipe dream. To say, like, given how high the maternity deaths were in the country, could this be possible to have a beacon of light, not just for the country, but for the sub-region? And I really think there's an opportunity here for the same thing to happen for breast cancer, to raise the awareness, to turn the tide for this crisis that we're witnessing today. So I envision a center of excellence in the future. So.
Thanks, Edgar. That's not a small dream, but I'm sure as many dreams it can come true. Kremelda, I'll hand over to you.
Well, that's a good one, Edgar. That's my dream too. A center of excellence, a well-equipped, dedicated cancer hospital in Sierra Leone. And of course, with specialized oncology personnel, including a radiotherapy unit. We need a radiation therapy in Sierra Leone. This will serve the sub-region, Liberia and Guinea. This facility is something I have been thinking about for such a long time, I'm saying, I showed you when you came, I said, I have that piece of land. I'm saying maybe that's where that hospital will be, because we need something like that. And also to intensify awareness and sensitization, because that's where it's going to start. We also need for the National Cancer Control Policy to become effective, because how can we move forward without one? We need skilled multidisciplinary team. We need Max Foundation and ABC Global Alliance. You have taken the vision. Max Foundation has. We just need the collaboration, the intense partnership, and the love for all of us. We need all of us in this. This is just not one man's dream. This is a multidisciplinary team to be strong so that we can take it forward. We need all of us.
Thank you, Kremelda. I think well said, related to collaboration. This is not something we can do by ourselves. So I want to hand over to Prof. I know, Prof, you have a lot of vision. There's a long list, but maybe you can share about your dream. You're muted, Prof. So we just can unmute you. Team, can we unmute Prof? Just give us a second, Prof. You're muted. Prof.
Yeah, sorry. So I want to appreciate all the panelists for their submission. Yesterday I was teaching my residents, and I told them that it's amazing that no cancer research is going on in Sierra Leone. That the few cancer researches that are going on is in this room that I'm seated, which is not what should be, because evidence is important in medicine to achieve whatever goal you have. So in addition to what people have said, we've been talking about early diagnosis. I think one of the barriers that I've noticed is after I am diagnosed, what is going to happen to me next? Cancer drugs are not in essential drug list in this country. There's no government pharmacy that has even tamoxifen. You still have to buy it outside. So as much as we are trying to create awareness, after the diagnosis, what happens? I think that's a big question that a lot of patients have to really ask. And we don't have answers for them. I know that if government has put cancer drugs in the essential drug list, it will make it cheaper for the patients. And I think this is one thing that we have to keep working on as advocates, as healthcare professionals, as collaborators. Anywhere that I have the opportunity, I remember November last year, I had close to one-on-one with the president of the country, and this was part of what I told him. I said, yes, we're talking cancer, cancer, cancer. But we need the help of government in this area. And I mentioned radiotherapy, that radiotherapy is key to cancer management. We have to get it. But you can imagine where we don't even have cancer drugs, and we are talking radiotherapy. Every cancer drug is in the hand of private people who are just for profit and profit alone. So we need that. We need to improve our diagnostic, and I want to thank Mass Foundation for that. I think things will get better for breast cancer patients, not just breast cancer, but a patient with CML also. Because I discussed with them in Ghana that we are going to include CML. My friend is the one doing it for you in Ghana. So we had a very long discussion there, and they are willing to support us. And my resident is also doing very well, because we talk about if there's nobody to give the treatment, we don't have a functional hematologist in this country. We are just having one resident. So we need to improve on personnel training for cancer across board, not just breast, all cancers. Improve diagnosis, and when diagnosis is made, they have to have what to use. I remember I worked under a professor of hematology, and they brought a new equipment to our department there. I was on rotation in hematology, and they told the woman, an older woman, oh, just put a drop of blood and all the tests will happen, all the results will come. She said she won't do the test. I said, why, ma? You have taught us so much. He said, oh, so when they find out that this is it, what are you going to give to me to treat it? That is better for me not to know and die than knowing and becoming helpless. I think that's what would describe the state of cancer in this country. It is good to say, okay, we will diagnose it. After diagnosis, what happens? So we need Mass Foundation to support us with drugs. We need Max Foundation to support us with diagnostic things. And we also need Max Foundation to help with collaboration in research, so that people will see what we are doing, and you just get a call from somewhere. Oh, we saw this publication from your country. How can we collaborate with you? I told you guys when you were here, even the histology that we are doing here this year, this is September ending, 70% of the reagent and consumables in the lab, they come directly from my collaboration with people on research. We are not even getting consumables to be bought by the hospital. So these are fundamental issues. But thank God that I had some research going on by the side, and I'm able to continue running the lab on the research fund. Something that probably should come to my pocket as part of the hours that I give. I have channeled it to getting reagents and all that for the department to work. So if there is research going on, we can leverage on that, and some small resources can go into helping patients to have a good life. I think that's my dream for the country, for cancer to be well managed, and all hands must be on deck. So from your hand, Edgar Thomas, you are a son of the soil. If you have any influence on the government, you have those in power, let them talk. They have to separate cancer from NCDs. There's no country lodging cancer with NCD.
Yeah.
There's no basis for that association. Cancer has to be separated, and it has to have a directorate so that it can better be managed.
Yeah.
Very much.
Thank you, Prof. I want to say from the wish list here of all the panelists that presented from Sierra Leone, the call to action was, as Prof now put it, to Max, but I want to push this call to action out to everybody on this call and all the partners that will still listen. This is not just the Max Foundation. This is a collaboration, as I've heard through the panelists as well. This is about a community, and we can see the passion and the need that is being presented through the panelists today. And the time to change it is now. There is a critical need for access to treatment, for diagnostics. There is a critical need for change within the system, and as a community and as partners, we can help support those in country to actually change that. We've come to the end of my formal questions. I see Prof has actually just dropped mic'd and left the room. But if there are any questions in the chat, I would advise you to put them there. There was one question that stood out. I'll maybe just refer to that. And then we'll close the session as we are running out of time. The question was, I cannot see who the question was from, but there is one I'll add to Crimelda. What advice would you give to other patients or patient advocates in similar situations who do not have existing disease support groups in their area? Crimelda, you're on mute. So I'll
Yes,
repeat the question for you.
please,
It is,
yes.
what advice would you give to other patients or patient advocates in similar situations who do not have an existing disease support group in their area?
It will have to be advocacy. We have to raise our voices. We have to be strategic. We have to meet the powers that be. I've been working on that. For Sierra Leone to be talking about NCCP, I came from the time I met you at UICC. I came home with that. And I went to the Ministry of Health and told them, we cannot go forward without a national cancer control policy. And so it's about advocacy, and more advocacy. And we cannot stop. It's your passion. It's something you believe in. You've seen the tears, you've seen the pain. So you cannot stop. You have to raise the awareness and lift up your voice and advocate for those that are voiceless.
Thank you, Crimelda. Peter, your hand is up. I'm handing it over to you.
Thank you. I also saw a question about getting, how to improve access to proper diagnosis, and that also joins my dream. Is really getting your basics right. Okay, it's a great idea to have a center of excellence, but also the small centers out there, they have to be excellent in what they can do. They don't have to be excellent because they can do everything, but they have to be excellent in what they can do, and that what they can do. And it has to be, and then we have tried to do that in Botswana, is to get the diagnosis there earlier by detecting in time, by doing a biopsy locally, either through through-cut biopsy, that's the best way, FNA, or if nothing of that is available, incisional biopsy. And if we can do that in an excellent way, then we'll improve a lot of things. And then comes another thing, is that, of course, get the treatment, the basics of treatment have to be there. It won't cost an arm and a leg. I mean, those basic treatments aren't that expensive, particularly if you buy them centrally through, for example, through the IDA. That's going to help a lot. And then if you can get a radiotherapy machine in through the IAEA, that will also be affordable. And then once you have that in place, then you can start thinking about more expensive things. Because people always like to fund or buy things, machines and buildings and all that. It's not about that. It's about getting the basics right. That's what we have to spend time and money on. And then once that is in place, then we can start thinking vaguely about mammography and all these things. But very often people think about mammography first, but people can't treat what they detect.
Yeah. I think that leads to a question I've just seen come up in the chat is it valuable to have pathology centers of excellence for pathology instead of diluting resources across a region? So I expect the question is if we combine the resources in one center and refer to one center for pathology in a country or in a region, would that be beneficial? And Fatima, your hand is up.
Yeah, I was going to just answer that part of centralization, decentralization. So that is a very difficult decision to make in all countries. It's not just low middle income countries. On one hand, you want the resources to be close to the patients, but on the other hand, you want the resources to have sufficient experience. And if you have everything diluted in the smaller hospitals, you will not have experienced pathologists, experienced surgeons. So there has to be a mix of centralization so that you have the experts with a lot of experience and knowledge. And then you have to work on your referral networks. And for that, the work of advocacy is not just for the general public, and Cremelda knows this very well, is also educating the healthcare professionals that are on the primary care so that they don't miss the diagnosis, that they refer quickly to the more centralized hospital. So working in network is the best thing for the patient because it provides the expertise, but it has to, at the same time, help them reach the expertise by transportation, network, referrals, and used. That's where I think the new technologies can help. The telemedicine can help because there's a lot that you can do virtually these days, including telepathology. So I think investment there would be really more important than to buy a lot of mammography machines, like Peter was saying.
Thank you, Prof. Prof, I want to give you just a quick option to respond because we are running out of time. I'm aware of our session, but please go ahead.
Okay, thank you very much. I just wanted to say something about the pathology being centralized. Yeah, because I've worked across West Africa, I can tell you there are quite a number of countries that have good pathology system, including even some are doing molecular studies. I think that what we can do is to make sure that, at least for breast cancer, all the countries that Max Foundation is should have minimum thing to make a diagnosis that will lead us to treatment options. That is key. It will not only help the patient, it will help training of personnel in that country. All right? This is very important. Thank you.
Thank you, Prof. And I also saw a comment from Pat saying, thank you for being such a great, passionate champion for your country. So we really appreciate your voice as well. And we take to heart what you were saying. But I want to step back and say thank you to the panelists that joined us today in this discussion. I personally, and I know the organization as well, value your expertise, your knowledge, and your friendship and partnership as we walk along on this journey, and not just try and change the lives of patients in Sierra Leone, but across the world. So this is a mission we all take up our hands for together. I want to thank the audience that joined. I know we're running out of time, but I do want you to stick around for 2 more minutes if you can. And I want to just remind everybody that tomorrow is the date where we kick off Breast Cancer Awareness Month. There will be several events. If you're interested in directly supporting Max's breast cancer programs, I want to invite you to visit the link through this QR code on the screen. Any contribution you make will go directly towards the support the efforts that we have in reaching more women affected by breast cancer, and it will make a tangible difference in their lives. You've heard so many opinions today, but I can also share so many stories that I've seen being changed, patients being changed by this program and our efforts. I want to say as well, take a moment to thank all our global supporters who have helped us on this journey so far to bridge the gap in access to treatment. And we do know that we are working together on a healthier future. So thank you for those joining. I want to take, if there's a second, maybe just to hand over to Dr. Cardosa again to speak about their event, the 8th Annual International Consensus Conference for Advanced Breast Cancer. Prof,
Just
or
a
Doctor?
quick quick invitation to everybody who would like to attend the conference. It's a hybrid conference, so if you cannot come, there is the opportunity to attend virtually. And the goal is to write the consensus guidelines on how to manage advanced breast cancer that then can be adapted to the resources in all the regions and countries. So please join us in our work.
Thank you, Dr. Cardosa. Indeed, a very valuable event. So in terms of policy and treatment procedures, this is the way to also add your voice specifically from the low middle income countries. And then Crimelda, I'm giving you the spotlight again. You also have events coming up this Breast Cancer Month if you want to spotlight that to our audience. You are muted.
Yeah. Thank you.
Thank you.
Yes, in commemoration of Breast Cancer Awareness Month, which starts tomorrow, on the 17th, we'll be having our Pink Friday and Health Fair. This is like a one-stop health check where we will check breast screening, blood sugar checkup, hepatitis, eye exam, HIV/AIDS, malaria, typhoid, and also as part of our physical activity awareness campaign, there'll be the Freetown Half Marathon on October 25th. Hope for a cure. T-shirts are out and we will run to help save a life. So everyone is invited. Thank you.
Thank you, Crimelda. I might miss this one, but maybe next year I'll have to get the running shoes on and fit for that one.
Thank you.
I again want to, as the sun is setting here in my side of the world in South Africa, I see we've had an audience from India, Cambodia, Rwanda, Kenya, South Africa, and the US, wherever you are in your day. Again, thank you for joining us. May you have a fantastic evening, morning, or afternoon. And thank you for taking this up as one of the causes that you will support. And thank you again to the panelists. Have a great day.